So friends, after we have seen what is acute pancreatitis, now we'll see what is chronic pancreatitis. What are the etiological factors for chronic pancreatitis? So alcohol is the most common factor for causing chronic pancreatitis. In 70% of the etiological factors it is alcohol induced chronic pancreatitis. Next is idiopathic, including tropical causes of pancreatitis, which is tropical etiology, is seen in 20% of the patients. So friends, here is the difference. So if you are asked what are the most common causes of acute pancreatitis, it is biliary stone, and what is the most common cause of chronic pancreatitis, it is alcohol. So you should note this difference very well. Next comes this is hereditary pancreatitis. It is then hyperparathyroidism, then hypertriglyceridemia. So raised triglycerides more than 800 to 900, they will cause recurrent attacks of pancreatitis. Then comes autoimmune pancreatitis. Then there will be obstruction of pancreatic duct. Then the trauma which will be occurring repeatedly. So in cases of various types of endotherapy, they may cause repeat attacks of pancreatitis. Or in pancreas divisum, where the two ducts separately drain the dorsal and ventral bud of pancreas, and if they are not well developed, they will cause mild form of obstruction and will cause repeated attacks of pancreatitis. Next we have got chronic calcifying or lithogenic pancreatitis. Then we have got hereditary pancreatitis. We have got tropical pancreatitis, hyperlipidemia, hypercalcemia, drug induced, and idiopathic. We'll see chronic obstructive pancreatitis. So this refers to chronic inflammatory changes which are caused by compression or occlusion of the proximal ductal system, either by tumor, gallstone, or post-traumatic scar, or inadequate duct caliber, as seen in pancreatic divisum. Next we have got tropical or nutritional pancreatitis. It is seen in Indonesia, South India, and tropical Africa. Many of the patients appear malnourished. The characteristic cyanotic coloration of the lips may be seen. The cassava root, which is starch, it is origin of tapioca, which is the staple diet throughout Afro-Asian region where tropical pancreatitis is prevalent. So we will see how cassava root causes chronic pancreatitis. So cassava contains toxic glycosides which form hydrocyanic acid when they get mixed with gastric hydrochloric acid. So this hydrocyanic acid is reduced to thiocyanate, which will block variety of enzymes including superoxide dismutase. So these all the enzymes which are antioxidants which are blocked, then they will cause oxidants to act and they will cause repeated attacks of pancreatitis. The simultaneous deficiency of dietary trace elements such as zinc, copper, and selenium could retard the detoxification of cyanogens, and they result in increased susceptibility of free radical injury to the pancreas. So these free radicals, they will cause repeated attacks of pancreatitis and ultimately leading to the chronic pancreatitis. Then there will be stone formation. So how do stones form chronic pancreatitis? So pancreatic stones are composed largely of calcium carbonate crystals trapped in matrix of fibrillin and other material. So if you are asked question which is the most common material of which the stones of chronic pancreatitis are formed, it is the calcium carbonate crystals. So friends, we have seen what are the etiological factors of chronic pancreatitis. So there is a multiple hit theory behind formation of chronic pancreatitis. So multiple attacks of acute pancreatitis or pancreatitis which is in mild form, if the attack gets at frequent intervals, then patient will develop chronic pancreatitis over a duration of period. So pain in chronic pancreatitis is due to three etiologies. There will be ductal hypertension due to stricture or stones, which may predispose to pain that is initiated or exacerbated by eating. So if you have got obstruction in duct and after eating there will be secretion of pancreatic enzymes, there will be ductal hypertension because the secretions get accumulated in the pancreas. The chronic pain without exacerbation may be related to the parenchymal disease or retroperitoneal inflammation with persistent neural involvement. The acute exacerbation of pain in the setting of chronic pain may be due to acute increases in ductal pressure or recurrent attacks of pancreatitis. So strategies to relieve pain are therefore based on three approaches. So as compared to the acute pancreatitis, the main approach to chronic pancreatitis is relieving of the pain. But in acute pancreatitis, you have to resuscitate. The first modality to relieve pain is to reduce secretion and decompress the secretory compartment. Then you have to resect the focus of chronic inflammatory change. You have to interrupt the transmission of afferent neural impulses through neural ablative procedures. So in chronic pancreatitis, these are three main principles. So if you have got question, the modalities on which the chronic pancreatitis management depends on all except. So these are three modalities and they will give you some distractor or which is not proper answer. So you have to pick the accordingly. So then they will also give like relieving of the secretions by using of resuscitative measures as a distractor in the fourth MCQ option. So you have to pick, you have to know what are the correct options and you have to mark out the wrong one. There will be malabsorption and weight loss. There may be severe steatorrhea which will cause formation of orange oily stool. So in a chronic pancreatitis, if you are given a clinical scenario, a patient which is malnourished, which will present with chronic stools which patient complains of having oil like and which will float on water. So which of the following conditions or how do you evaluate these patients or which you suspect? So if you are given a clinical scenario of chronic pancreatitis, you have to mark out which is the investigation of choice. As exocrine deficiency increases, the symptom of steatorrhea are more often accompanied by weight loss. So many of the patients which will have chronic pancreatitis will have chronic effects of chronic pancreatitis, which may be formation of pancreatogenic diabetes. In chronic pancreatitis, acinar tissue is lost, replaced by fibrosis, which is greater than the degree of loss of islet tissues. So although the islets are typically smaller than normal and may be isolated from their surrounding vascular network by fibrosis. So with the progressive destruction of the gland, the endocrine insufficiency commonly occurs. So first there will be exocrine insufficiency and later on there will be endocrine insufficiency. So how do you investigate the patients of chronic pancreatitis? It is by transabdominal sonography. Then you have got endoscopic ultrasound. Then you have got laparoscopic ultrasound. So if you contemplate this patient to laparoscopic maneuvers, we have got MRCP. Among all these investigations, the ERCP is considered to be gold standard for diagnosis and staging of chronic pancreatitis. So in a MCQ question for chronic pancreatitis, which is the gold standard investigation, it is ERCP. Because it will diagnose things, so it will give you multiple chain of legs appearance. Along with the, it will show you various dilatations and stone formation and various strictures or various types of ducts. So you may give endotherapy in the same setting when you contemplate ERCP. So it is a gold standard investigation. CT scanning has affected the diagnosis of pancreatic disease more broadly than any other method. So before ERCP, CT scan is done to assess how the things are there in pancreas. So ERCP is considered most sensitive test for diagnosis of chronic pancreatitis. CT scan will show calcification, duct dilatation or cystic formation of the duct. CT is helpful as a screening study to guide interventional therapy. So as I told you earlier, before intervention CT is done. EUS has an advantage of very high resolution images of pancreatic parenchyma. The main and secondary ductal system, cystic lesions are assessed well and calcific changes are noticed. If you have got a cyst formation in chronic pancreatitis, so if you are asked which of the investigation is done, it is EUS. Because with the EUS, you can take fluid from the cyst because there are various cystic neoplasms of the pancreas as we are going to see in later. So various cystic neoplasms of the pancreas, they are evaluated after the cyst fluid analysis. So if CT scan will show you cyst formation, so which is the next investigation of choice? So if you are asked question where the cyst formation is there, it is not ERCP, it is the EUS. So you should not confuse between chronic pancreatitis which is not having cyst. So chronic pancreatitis which is not having cyst, it is evaluated after CT scan with ERCP. And chronic pancreatitis which is having cyst, which is evaluated by EUS after CT scan. So these differences you should note down. So we have got Cambridge classification of chronic pancreatitis by ERCP. The quantification of stool fat has also been used as a measure of pancreatic lipase secretion, either through direct measurement of total fecal fat levels while the subject consumes diet known fat content. So chronic pancreatitis, the fat assay, stool fat assay is done to label the patient as enzyme deficient. So measurement of XL CO2, which is 14 CO2 after ingestion of 14C, which is 14C olein. This is also called as triolin breath test, but it has got a high false negative rate. So you may be given various types of tests which are done for chronic pancreatitis. So you should know all the tests which are done for chronic pancreatitis to pick up the test which is not used for diagnosing chronic pancreatitis. So in addition to the progressive endocrine and exocrine dysfunction, there will be risk of development of pancreatic carcinoma. So whenever the patient of chronic pancreatitis has got diabetes which is getting added up, you should suspect pancreatic carcinoma. So now friends, we will see what are the complications of pancreatitis. So there will be pseudocyst formation. So we'll see some few definitions which may be common to be used after acute pancreatitis and after chronic pancreatitis. So we'll see what is pseudocyst. A chronic collection of pancreatic fluid surrounded by a non-epithelialized wall of granulation tissue and fibrosis, which is referred as pseudocyst. So friends, you may be given various types of definition and you may be asked what this is called. So you will have acute pseudocyst, chronic pseudocyst, or acute fluid collection, or peripancreatic infected necrosis. So you have to go through these definitions very thoroughly, because there is very minor change in these definitions which will lead to the diagnosis. So we have seen what is definition of pseudocyst. Now we will see what is peripancreatic fluid collection, which is a collection of enzyme-rich pancreatic juice which occurs early in the course of acute pancreatitis, or which forms after pancreatic duct leak, which is located in or near pancreas, and it lacks a well-organized wall of granulation and fibrous tissue. So peripancreatic fluid collection and pseudocyst, they differentiate from each other by lacking of organized wall of granulation or fibrous tissue. So this is very minor difference that should be noted by you. We got next is early pancreatic, which is sterile necrosis, which is defined by a focal or diffuse area of non-viable pancreatic parenchyma, typically occupying more than 30% of the gland and containing liquefied debris and fluid. Then we have got late pancreatic, which is also sterile necrosis, which is defined by an organized collection of sterile necrotic debris and a fluid with a well-defined margin or wall within normal domain of pancreas. What is acute pseudocyst? So acute pseudocyst is a collection of pancreatic juice enclosed within a perimeter of early granulation tissue, usually a consequence of acute pancreatitis which has occurred within preceding 3 to 4 weeks. You should know the difference between acute pseudocyst and chronic pseudocyst. So chronic pseudocyst is a collection of pancreatic fluid surrounded by a wall of normal granulation and fibrous tissue, usually persisting for more than 6 weeks. So pseudocyst is a fluid collection which has got a definitive wall. So early pseudocyst and chronic pseudocyst, they are differentiated from each other by normal granulation tissue which will be persisting after 6 weeks, which is called as chronic pseudocyst. There are very minor changes in definitions. You should note them. Then next we have got pancreatic abscess. So any of above in which gross purulence or pus is present with bacterial or fungal organisms which are documented to be present, which is called as pancreatic abscess. So whenever you have got pancreatic pseudocyst, which is acute, chronic, and formation of pus in it, which is documented by aspiration, you have to label it as pancreatic abscess. So it doesn't remain as pseudocyst, it gets converted into abscess. So if infection is suspected, the pseudocyst should be aspirated, not drained, by CT or USG guide fine needle aspiration, and contents examined for organism by gram stain and culture. So whenever you got infection which is suspected, so patient will have got fever, patient may have got downward trend, shock or decreased weight, you should suspect infection. The next choice of investigation is CT guided FNA, not the direct drainage. So in a given clinical scenario, if you are given a choice, which will be the next best possible investigation, it is CT guided FNA. If the infection is present and the contents resemble pus, then external drainage is employed using either surgical or percutaneous technique. So whenever after confirmation with the needle aspiration, if you get pus, then they should be drained externally, either by surgical or percutaneous technique. If the pseudocyst has failed to resolve with conservative therapy and symptoms persist, the internal drainage is usually preferred to external drainage to avoid complication of pancreatic or cutaneous fistula. So when you are drain and the drain continues. So you have to avoid all these situations because pseudocyst has failed to resolve. So all these patients where the pseudocyst have failed to resolve, so after observation of for quite few months, they should be subjected to internal drainage. So friends, now in the step ladder management of pseudocyst, so if you have got finding of duct leaking through ERCP on ERCP, if you have got communication with the duct, they should be offered internal drainage. And if you don't have got connection with the duct on ERCP, they should be offered external drainage. So external drainage or internal drainage of pseudocyst is based on communication with the duct. And external drainage, where there is infection, you have to drain externally, not internally. Pseudocysts communicate with pancreatic ductal system in up to 80% of cases. So external drainage creates a pathway of pancreatic duct leakage to the catheter exit site. So whenever there is suspect the pancreatic duct communication, the external drainage is avoided. Next we have got what is pancreatic ascites. So when a disrupted pancreatic duct leads to the fluid extravasation that does not become sequestered as pseudocyst but drains freely into the peritoneal cavity, the pancreatic ascites occurs. Occasionally, the pancreatic fluid tracks superiorly into thorax and pancreatic pleural effusion occurs. So, whenever pancreatic duct leaks and it causes exudation of fluid in the pre-peritoneal cavity, so it is diagnosed based by tapping of the peritoneal ascites and quantification of amylase. So, patient will have got raised serum amylase because all the amylase in the fluid may be getting absorbed. What is the treatment? The ERCP and stenting of the pancreatic duct is the treatment for pancreatic ascites. Then we have got anti-secretory therapy with somatostatin analog, which is octreotide acetate, together with bowel rest and parenteral nutrition. So somatostatin analog, which is octreotide, which may be also used in acute pancreatitis where its role is doubtful. But octreotide has definitely role in post-surgical to prevent the pancreatitis after surgery. And pancreatitis is seen in biliary pancreatitis. So where the octreotide has some definitely role. So which of the following conditions where the octreotide has helped in acute pancreatitis, where they will give an option either post-surgery or gallstone pancreatitis, which is what got definitive role in management of pancreatitis. But alcohol-induced and other traumatic pancreatitis where you may not have got good role of octreotide in management of acute pancreatitis. In chronic pancreatitis, in pancreatic ascites, the octreotide has a role to prevent further duct leak and to reduce the pancreatic ascites. So internal drainage by Roux-en-Y pancreaticojejunostomy is done for pancreatic ascites. Or you may do endotherapy, as I told you earlier, by ERCP. So now we'll see treatment options for chronic pancreatitis. It is by medical therapy. It is by analgesia. So pain is very important component for the chronic pancreatitis. Then they have got enzyme treatment, you have got anti-secretory treatment and neurolytic therapy. You have got endoscopic management by ERCP and various types of interventions to call them as endotherapy. You have got surgical therapy in a form of resectional procedures. Then you have got sphincteroplasty. So whenever there is obstruction at the ampulla, you have to do sphincteroplasty. So sphincteroplasty is dilatation of the sphincter, whereas the pancreatic sphincter choledocus and sphincter pancreaticus to dilate the sphincter and they will relieve the recurrent chronic pancreatitis. Then you have got drainage procedures. So there are various drainage which is called as Pusch's operation, or where you drain the pancreatic duct by lateral pancreaticojejunostomy. Then you have got the resectional procedures. So various resectional methods like near total pancreatectomy, distal pancreatectomy, or you have to core out the affected pancreatic tissue, as in called as Fraise procedure. So it is Fraise procedure where you have to core out the head along with the lateral pancreaticojejunostomy. So it is done in resectional procedures. You all also got the denervation procedures. So these denervation procedures which will include the various types of ganglion blockades. So you have to block the ganglions which are the celiac ganglion or sympathetic plexuses which will carry the pain fibers. So friends, we saw various types of chronic pancreatitis treatment in the form of medical therapy, the anti-secretory therapy. We saw various pathological events which will cause pain in chronic pancreatitis and what are the complications of chronic pancreatitis, various cyst formation or various types of pain management procedures we saw. Thank you.